our talk is about the association of comorbidities and socioeconomic deprivation among people who died with dementia in England between 2013 and 2023. First, giving a background on the subject, most people who die with dementia have coexisting physical and mental comorbidities. The relationship between these comorbidities and dementia is quite complex. Some of these conditions share clinical risk factors and share etiologies with dementia, like hypertension. Some of them share socioeconomic risk factors with dementia, like stroke, and some, like pneumonia and urinary infection, often they cause disease in end-stage dementia. As in advanced dementia, neurodegenerative processes diminish, for example, coughing and swallowing abilities, and increasing the likelihood of aspiration and subsequent pneumonia. And some comorbidities may occur independently, like cancer. Now, these comorbidities, they're associated with more rapid cognitive and functional decline. They lower the quality of life in people living with dementia, and they change the care needs and prognosis of dementia. Knowing more about these comorbidities that people living with dementia experience in their final years and who is most at risk can potentially inform caring for these multiple conditions. So our aim was to update a previous report by Public Health England in 2016, which looked at death certificates, and we aim to update it to understand the needs of people who are dying from dementia. And another aim was to explore the conditions that are recorded alongside dementia on death certificates and to test our hypothesis. We hypothesized that number of comorbidities at death is associated with levels of deprivation. Now, on our methods, we analyzed, we used the data set from Office for National Statistics, ONS, Public Health England Annual Mortality Extract. So what happens is that this data set includes information that is recorded on the medical certificates of causes of death from civil registry records. These medical certificates are, the details on them, are converted to ICD-10 codes at ONS using a coding software, and we looked at our population was the death certificates for people who were aged 18 or over at death, and those certificates that were registered in England between 2013 and 2023. Now, each of these death certificates, they include one primary and up to 15 contributory causes of death. So what does this mean? Primary or underlying causes of death is the disease that initiated the train of events that are directly linked to death. And contributory causes of death, they're part of the causal sequence of events leading or contributing to death. And we looked at the certificates that included dementia as primary or contributory cause of death. The way that we defined dementia was the presence of any ICD-10 code related to a dementia diagnosis. So we looked at the codes for Alzheimer's disease, vascular dementia, dementia with Lewy bodies and Parkinson's disease dementia, unspecified dementia, and other types of dementia. And for comorbidities, we defined it as any condition that was recorded on the death certificate as a cause of death, either primary or contributory, in addition to dementia. And we specifically looked at conditions that were recorded on 5% or more of the death certificates in our cohort. So we reported the number of people in England who died with a dementia recorded as a cause of death, either primary or contributory. We looked at the subtype diagnosis of dementia and year of death registration. We also looked at socio-demographic factors, including sex, age at death, which we defined in groups of 10 years, under 65, 66 to 75, 76 to 85, 86 to 95, and those over 95 years old. Death certificates do not record information on the ethnicity. However, they record country of birth. So this was also something that we looked at. And at the end, socioeconomic status, which we looked at area deprivation, which was defined using index of multiple deprivation, IMD quintiles. Quintile 1 was the highest socioeconomic deprivation level, and quintile 5 was the lowest. Now we're going to move on to results. Claudia, if you could.
Thank you, Sedigheh. Hello, everybody. I'm Claudia Cooper. I'm co-director with Shubi Banerjee of the Dementia and Neurodegeneration Policy Research Unit based at Queen Mary. Just to explain a little bit of the context to this study, first of all, Sedigheh, who you heard from just then, is one of our postdoctoral researchers who has been doing a secondment for the past year and working 1 day a week for the Department of Health and Social Care, which has been fantastic because it's really enabled us to understand our customers' perspectives. And it was so successful, we've done it again. And one of our other postdocs, Harriet Dednitz-King, is just starting off with a second secondment. So this was work undertaken by Sedigheh when she was at DHSE with Michael Jackson's team and also with us. And that gave a great opportunity to put Sedigheh's inestimable quantitative skills to work on these very interesting data sets. So what did she find? Well, there were just under 1 million deaths in which dementia was reported as a cause. And we distinguished between the 70% where dementia was recorded as the primary cause of death, and what would that be? 30% in which it was a contributory, but there was another primary cause. One of the things that I know Sedigheh found very interesting was looking at the subtypes of dementia that were recorded on the death certificate. This obviously gives us a certain sort of view, certain perception of what conditions people living with dementia have. And in line with other work, unfortunately, 50% of dementias were unspecified. And we know that I work in a memory service myself, and there is a real need for us to increase the number of specific dementia diagnoses that we make. There's some limitations to this data because it might have been known in life, but not recorded by the person filling in the death certificate, who sometimes would be in hospital, whereas the notes might be more in the community. Otherwise, you can see the subtypes there. And here, as you might expect, there's been a sort of gradual rise, if you sort of let your eye coast along the x-axis over the years in the number of people dying with a dementia diagnosis, which is unsurprising because we know that over that time we've got a bit better at diagnosing it, and also that there are more people in the population, largely because we're an ageing population, living with dementia. And nobody will be surprised to see the peak in 2020 around the time of the pandemic. So this is interesting, and it updates a report from, as Sedigheh said, Public Health England. It's helpful for various reasons to have up-to-date information about who is dying with dementia. If you look at the subtype diagnoses across the quintiles, we didn't do any analysis on this, but looking at it, I think that I can be persuaded there might be some possible trends there. Lewy body dementia is almost certainly underdiagnosed. I think it was about 5% of people were dying with a subtype dementia of Lewy body, and we know from epidemiological studies that that should be higher. So one might wonder whether the fact that, as you can see, there's a rise in the number of people with that subtype diagnosis as you get towards the least deprived cohorts. And so there is a suspicion perhaps that there might be a certain inequality with people getting more precise and accurate diagnoses in line with the inverse care law, if in least deprived brackets. You can see a similar trend with other types of dementia. Unspecified dementia, I suppose I might have predicted that would go the other way. It doesn't quite, but it's likely that precision of diagnosis might well be an inequality. As Sedigheh alluded to in the introduction, we're not saying that all comorbidity is bad. The natural death with dementia is often to die with an end-stage pneumonia or a UTI. However, you wouldn't expect, if everybody was getting the best possible care and sort of had a level playing field, you wouldn't expect there to be many more comorbidities in people in more deprived areas than in lower. And that is what we very clearly found in this analysis. So if we think about the implications of this, that means that people who have dementia and the various comorbidities, and they have far more complex care needs, are highly overrepresented in more deprived and, as we know, underserved communities. And that's really worth thinking about, because as I'm sure hear many times in these webinars, if you think about access to palliative care, access to high quality care, unfortunately the need does go, as always, in the opposite direction to the services. So that is worth thinking about, and thinking about what tailored policy approaches one might take to levelling the playing field a bit there. So this is interesting. So where dementia contributed to death, these were the primary causes of death. I'd like to focus a little bit more on the, because I think it's easier to understand, when dementia was the primary cause of death, what other, on the right-hand side, contributors were there? Now, I don't like the word senility. The reality is this is a based on what people actually write on death certificates, and I think it's a shame to see that that is so commonly still recorded, because of course it's not a diagnosis, but there we are reporting what was there. Pneumonia and influenza, which often progresses to pneumonia, it's unsurprising to see that as a contributory cause of death, of course, because that is, as we said, one of the final common pathways often in death from severe dementia. I think some of the standouts for me here is just how common it is, the fact that 1 in 10 people with dementia also have cancer, and 1 in 10 people have diabetes, because there are some very specific care needs associated with those conditions. Next slide, please. So here we are. This is, I've been sort of doing our discussion as we go along, but I think, you know, if you think about how you care for somebody with diabetes, how you care for somebody with cancer, all the various NICE guidelines, all the documents that we have that guide us in how we deliver care to those conditions, there's very little written about how that care needs to be transfigured and transformed, really, in order to meet the needs of people who also have cognitive impairment, who of course will struggle enormously with regimens. There's safety issues with insulin and how that's delivered as people have dementia and diabetes. I'm a bit surprised not to see frailty on the list. Yes, indeed. Well, I was a bit surprised to see senility, and I have to say, I think in an early draft, I tried to take it out, and I'm quite right, said it didn't go, because this is actually reporting what was actually on there. So I don't know why frailty wasn't recorded, but perhaps Sedigheh might come back to that. It might be something about the way the analysis was done, because you looked at the top 5% of conditions, didn't you? Yeah. Okay. So it doesn't mean it wasn't there at all. So limitations, I've written one word, but I think it is the biggest one, is that if you're going to look at death certificates and extrapolate and say that you're going to make conclusions about the health of a population, one has to acknowledge the limitations in how accurately somebody's full health history is going to be recorded on a death certificate. And of course, that's particularly true, as I said, when they're completed in hospital. They may not be completed by somebody that knows the person well. But generally, we felt that this spoke to the need to account for the complexity of dementia care in policies to drive equity. So if we're thinking about how do we ensure that people living with dementia in more deprived communities get a diagnosis, get good care, it would be helpful to think about the fact that that care might be a bit different, it might be a bit more complex. I've just put a shout out to a very good paper that my PhD student wrote on this in COVID, when she went round and used various clever remote methods to actually record what it was like for people looking after people with dementia and other long-term conditions, and how they often struggled to and ended up adapting the care that they were asked to give and the support they were meant to give to what they could do given the situation that they were in. And I think it is an under thought about area. So thank you. I think that's our last slide, apart from our acknowledgements. There we go. Which is, as I said, a collaboration. So thank you very much. We take our slides down and we can take some questions. Although, Sedigheh, you may wish to add something to my answer to Emma's comment there earlier about frailty.
Yeah, so I cannot remember frailty in specific, but it was probably not recorded that often, probably less than 5%. So we did not brought it into the slides because it was so low.
Was the diagnosis cancer only, or did it specify which? If so, were there any trends? I think there are some figures, aren't there, Sedigheh, which will be coming out with the publication?
Yes.
Okay, so see our forthcoming publication. I don't remember any. I think the trends reflected the trends in the general population. I didn't eyeball it and see any surprises that things were going in a different direction. Is that fair, Sedigheh?
Yes, that's true.
Any other questions from the audience? Jose Luis, yes, please.
Thank you. Very interesting. So part of the aim of the study is to look at differences in outcomes or comorbidities across socioeconomic groups for people who've died now, with dementia. I wondered whether it would also be interesting to see whether those gradients, as it were, by socioeconomic status, when you focus on people with a recorded dementia diagnosis, are actually slightly different from those that die who do not have that recording, and therefore to understand whether those gradients are different and the extent to which dementia itself might be a contributing factor to the nature of that gradient. That would require you comparing those results you have against the equivalent results for those who are excluded from your analysis. I was wondering whether you're thinking about doing something like that.
Well, I am now. What do you think?
Yeah. Yeah, it would be really interesting. Unfortunately, we only had access to the death certificates of people who had dementia recorded, not the rest.
That explains.
Yes, it might be interesting at least to just sort of compare it to some data around. That would be fascinating. Thanks for that suggestion.
Yeah, I think one question I have is that apart from the IMD as a measure of socioeconomic status, is it possible to look at any other socioeconomic status indicators, for example, education or income wealth, any way to have this data set linked to other data sets so that you have more indicators in that domain?
Of course, I think there is a possibility to do link mortality records to CPRD or HES. However, it was not possible in this case because we only had access to this one data set. But I guess it is something that is done. When you're asking for CPRD, you can definitely ask for ONS mortality data, and it will probably give you more information, not education. However, I don't think any other primary care or secondary care or the ONS ones have information on education. And about socioeconomic status, I also think we only have IMD deciles in other ones as well, or raw numbers for IMD. However, I'm not sure.
And just to add that there's another study we're doing within DeNPRU that Sedigheh is also leading using CPRD, and we are going to link, aren't we, to mortality outcomes, also looking at comorbidities and to sort of tackling the question that you raised, Jose, from a slightly different angle, which is to look at what are the trajectories, what are the outcomes, what is the longevity of people who have, say, COPD and dementia compared to people who have dementia without COPD. and following that up over time. And we'll be doing that across neurodegenerative diseases and across long-term conditions. So Sedigheh has painstakingly developed a very detailed sort of model protocol, which we're now going to sort of start using to look across conditions, because it is helpful for policymakers, isn't it, to understand, you know, how the conditions might be transfigured or experienced differently depending on the comorbid neurodegenerative disease. So I think that would be very interesting. Well, thank you for the opportunity to come. Lovely to join you.
Thank you.
Claudia and Sedigheh.